Hi, everyone. It's an honor to welcome all of you to the Chicago Coalition for Family Building's complimentary webinar, Deciphering the Need, Who Benefits from Reproductive Surgery. Before we turn our event over to our moderator, I'd like to share a few housekeeping items. As you can see, your camera and sound have been turned off, so you don't have to worry about anything from your end. Any time during the webinar, you can use the Q&A functionality to ask a question, as there will be time at the end for our Q&A. And don't worry if you miss anything or have anyone that you think would benefit from hearing this today. This will be recorded and shared on our coalition website. And it's now my pleasure to turn the event over to our moderator, Dr. Eve Feinberg, Chicago Coalition for Family Building's board president and reproductive endocrinologist and fertility specialist, a medical director at Northwestern Fertility and Reproductive Medicine. Dr. Feinberg is one of the original founders of the coalition and is a fierce advocate for increasing access to fertility care. It's my pleasure to turn this over to Dr. Feinberg.
Thanks, Taryn, and thank you everyone for joining us, and especially huge thanks to Dr. Miller for joining us today. For those of you that don't know, Dr. Miller is a phenomenal reproductive endocrinologist and infertility specialist and gifted reproductive surgeon. He is also involved with the coalition and serves as a partner practice. And that is really paramount to helping individuals throughout Illinois and throughout Chicagoland meet our mission. Our mission is really this unwavering belief that everyone who wants to start a family deserves the chance. And since our founding, we've been fortunate enough to help bring 98 babies into this world. Yet we know that there are so many of you that are out there facing fertility issues, and we are here to help. And whether that help is through education, whether that help is through mentorship, or whether that help is through funding of fertility treatment, we really feel strongly at the coalition that we are here and we want to help. Today's webinar is focusing on just one aspect of many aspects within reproductive medicine, reproductive surgery. And with that, I'm very proud to welcome Dr. Charles Miller for a robust conversation. Dr. Miller is an internationally renowned expert in minimally invasive gynecologic surgery and in the treatment of infertility. He is the founder and medical director of the Advanced IVF Institute, the Advanced Gynecologic Surgery Institute, and the Advanced Fertility Preservation Institute. His practice joined the CCRM Fertility Network last year in 2023. He is a professor of OBGYN at Rosalind Franklin University of Medicine and also serves as the director of minimally invasive gynecologic surgery at Lutheran General Hospital. So without further ado, Dr. Miller.
We don't have any time left, do we?
Let's start out, like, what is a reproductive surgeon? I think that's a really good starting place. And I want you to talk a little bit about that.
Well, thanks. I think first of all, thanks for letting me be here, and thanks, Faring, for being part of the educational system for the coalition. I think it's just marvelous. You know, it's a reproductive surgeon has an important place because, let's face it, as an infertility specialist, you understand female infertility, you understand male infertility, we understand eggs, we understand cycles, etc., etc. On the other hand, MIG surgeon, minimally invasive gynecologic surgeons, understand endometriosis. Oftentimes, pain-related endometriosis or pain-related fibroids or fibroids that are associated with bleeding. But it's that reproductive surgeon who is the bridge between the needs of the reproductive endocrinologist to enhance her or his patient's fertility treatment and the MIG surgeon to understand where the surgery will enhance the ability to achieve pregnancy. And I do see there's becoming more and more of an importance of that surgeon to add to the mix.
Yeah, I mean, I definitely agree. And I think we're going to talk about a few distinct types of things that require reproductive surgery, but in my own observation, I mean, in part, as women start to get older, we see more things like fibroids. As women have more cesarean sections, we start to see things like isthmoseals and cesarean
Right.
section defects. As women get older, they have more miscarriages, which then may lead to scar tissue inside
Right.
the uterus. And so I think like there are a plethora of different indications for why reproductive surgery is performed. And I think like my goal for today is to break it down and talk about some of those different types of surgeries, as well as some of the decision making that goes into it. Not everyone who has a fibroid needs to have surgery, but maybe that's a really good starting point to
Absolutely.
say, like, who does need surgery with
Absolutely. I mean,
fibroids?
you mentioned three situations. You mentioned fibroids, you mentioned the C-section defect, the isthmoseal, the niche, depending on how where you are in the world, as well as intrauterine adhesions. All of them may be non-problematic. All of them may be problematic. Let's start with fibroids. So we know that 50% of women by the age of 30 have fibroids. Certainly not all women's pregnancy or ability to achieve pregnancy is going to be compromised by fibroids. But there are cases where fibroids are problematic. Certainly we all agree that fibroids inside the uterine cavity can disrupt implantation and not only lead to lower chances of pregnancy, but higher issues of miscarriage. There has been, through the years, some debate of whether fibroids near the cavity also cause a problem. Well, we know from a meta-analysis from a large study that was done by a friend of both of ours, Elizabeth Pritz in Madison, in about 2010, I believe, showed that even fibroids near the cavity are going to be problematic. Now, what does that mean? Here's where the reproductive surgeon gets involved. Is that I'm going to look at a fibroid and say, okay, that is impacting pregnancy. Or I may look at that fibroid and say, yes, that's close to the cavity, but it's not that big and it's not in a position where I think it's really going to matter. Let's go ahead and deal with trying to get pregnant. The other thing that is in the hands of the reproductive surgeon is perhaps a minimally invasive surgeon would say, okay, if I'm going to take that fibroid near the cavity, I'm going to go ahead and excise it via the laparoscope, via the abdomen. So I'm going to cut into the uterus, take out the fibroid, repair the uterus. As opposed to a reproductive surgeon may think, yeah, but if I do that, then that patient's going to need a cesarean section. So what if I went ahead and do it hysteroscopically through a telescope that is placed through the vagina, through the cervix, into the uterus, and we remove the fibroid that way. That way, once pregnancy is achieved, that patient can still have a vaginal delivery. So these are the things that we're constantly looking at. Is there a need? If there is a need, how do we approach it?
Yeah, and I think my big question, I think one of the things that we all struggle with the most is who needs to have a fibroid removed. So I think, you had started to talk a little bit about how there are different types of fibroids. And I think about this very simplistically. There's fibroids that are 100% within the uterine cavity, and those need to come out. There are fibroids that are in the muscle layer of the uterus, and that's maybe where some of the finer decision points come in. And then there's a third layer of fibroids that are on the skin layer of the uterus or the serosa, and those usually don't need to come out. So then
And I agree,
focusing,
except there's a caveat there.
yep,
And I think if you truly have a fibroid on the outside and that patient is going to get IVF, you have to make sure it's not in the way of our ability to access those eggs. The other thing is that always somewhat of a concern when you have particularly what we call a type 7 fibroid that's really outside the uterus, like you're talking about, but it's huge. The problem is that fibroid, now no one has a crystal ball, but during pregnancy, as the uterus grows and the fibroid grows, it may outstrip its blood supply. So there's a very rare case that I will say, oh my gosh, because this fibroid is so big, I'm concerned that it could break down and you have tremendous pain. But usually you are correct. The fibroids inside the cavity, whether all in or mainly in, or it's a good sized fibroid that's still in, I believe have to go. The fibroids next to the cavity of any good size should be removed. A fibroid that's a moderate size, I look to see how that patient is implanted. Now, if that patient has continuous implantation failure and we don't understand why, then I consider myomectomy. Because we do know, as you know, I'm talking to the speaking of choir here, but for the audience, fibroids can disrupt blood flow and therefore disrupt implantation.
And so is there a size limit? So if you were to see a new patient who comes to you for the very first time, she is infertile. They've been trying to conceive for 2 years. They have not yet done IVF. We don't know how she's going to implant once you take an embryo and transfer that embryo. Is there a size where you would look at a fibroid that is within the muscle layer and say right off the bat, this needs to come out? Or how do you navigate those situations?
I would say there have been some studies, or an Italian study that was done a few years ago that looked at fibroids 5 centimeters or greater. And these were done laparoscopically, and it showed that there was a higher rate of pregnancy. Back in the day, in the late 1990s, I did a study with fibroids 4 centimeters or greater that were at least 4 millimeters or closer to the endometrium. And these were women who were either continually miscarrying or were not getting pregnant with primary infertility. And all other factors were accounted for. And in these women who had 0 success, we ended up having a 75% pregnancy rate and a 70% delivery rate. Eve, you know as well as I do, as a brilliant researcher, it is problematic when we start talking about these kind of studies, because it sounds great. And I'm sure that the people listening in are saying, man, that was really good. But here's the caveat. The problem is that the comparison group. Were we to have just left someone trying on their own without treatment, would some of these gone on to success over the time? The trouble we get into as practitioners is that we get a sense of what is right for our patients, and therefore are unwilling to put people into a group that's not treated versus a group that is treated with surgery. So we do our surgical treatment and we glow in our success, and that becomes what we do. But I guess on the basis of a couple studies from Dr. Rossetti and myself, 4 to 5 centimeters would be where I look, especially on top of the cap.
Yeah, I think that's really helpful. And I think that's a pretty careful guidance. There were some studies that looked at fibroids that are 3 centimeters,
Yeah.
Stovall studies, and I
Yeah,
think that's
so
just a little bit on the small side where I wouldn't necessarily advocate for removal of those fibroids.
but
Um,
let me ask you, you have someone who implantation failure now is coming for their third or fourth transfer of a genetically normal embryo, and you're just going, what would you do?
Well, and I think that situation is different. I think
Yeah,
in a situation of somebody who has chromosomally normal embryos, they've transferred 3 or 4, there's no other explanation as to why. Those are the situations where I
yeah,
do think about fibroid removal, even when the fibroids are a little bit smaller, if they are close to the uterine cavity.
yeah.
And
And
so
I
I
can
think,
tell you that is someone, Eve, that, I guess because of what I do surgically,
mm,
that is a group of patients that I will see that others have not operated on, and I've taken to surgery and certainly see success. But
yeah.
again, to say that this is the key, no, no.
Yeah, and I think there's a big difference between taking somebody to surgery a priori without infertility treatment. And then I always think of infertility treatment as we're peeling back the layers a little bit and we're learning more as we go. It's always a balance. You don't want to do too much too soon, but you don't want to ignore something that may be a factor as to why IVF is not successful.
Eve, I'm sorry because I would love to have said that myself. That's probably the most important statement of the day. Yes.
And how do you counsel? And I think the caution with surgery for our listeners, I think everything that we do has consequences. Everything that we do has risks, and there's a risk of operation and there's a risk of non-operation.
Yeah.
How do you counsel patients on the risk of operation? Like, what
Well,
are the risks of
let's
myomectomy?
talk about that because perhaps there's no other more important area when we come to counseling patients than is the ovarian endometrioma, the cyst of endometriosis in the ovary. And in fact, I'm doing a webinar later this week with ASRM just to talk about this.
Mhm.
Because on the one hand, you leave an endometrioma of any consequential size over time, it can have a negative effect on ovarian function. If you look at studies that look at other types of ovarian cysts and endometriomas in the ovaries, there's more compromise to ovarian health leaving the endometrioma. On the other hand, as you well know, the ovary, the cyst removal can be an absolute disaster in terms of lowering ovarian health. And so, in your zealousness to enhance someone's ability to achieve pregnancy, you may, in fact, be reducing that patient's pregnancy long term, chances of pregnancy long
Mhm.
term. So, as a result, the necessity to properly inform that patient as to risks on both sides is absolutely important. Okay. Not only if you leave the cyst can it be detrimental to ovarian health, but in the process of retrieving eggs, there can be a problem with egg retrieval, and you end up hitting the endometrioma. The endometrioma gets infected, and I can tell you there's no worse infection. It wipes out ovarian function on that ovary. So we have these discussions. Okay, and I've spent a lot of time with this. I wrote an article in JMIG a couple of years ago that's become a well-referenced article about the endometrioma decision tree. We look at it from a standpoint of is there an impact? I do believe endometriosis has an impact on subsequent implantation. So if I have a patient with an endometrioma who's involved with fertility, I will want to wait to operate on that patient until I'm at a point of doing IVF. I do not believe that to enhance someone's chances to get spontaneously pregnant in Chicagoland, where we have such great access to IVF, is the way to go. We ought to wait until we deal with IVF. And then, if possible, do IVF first before doing surgery. That's number one. If I can get follicles before surgery, that's the way to go. Once I have my eggs, once I have my embryos, then prior to implantation, to enhance implantation, I would deal with surgery. If I cannot get those eggs out, and there's not significant number of eggs on the other side because of the position of the ovary, of the endometrioma, I talked about removing the endometrioma. But again, I don't want to. Next, if there's problems, the last thing is, if there's problems, if I have someone who really has poor egg numbers, we do know that oftentimes endometrioma treatment can enhance egg numbers. There's been a number of studies that have shown that. We actually won the award for Society of Reproductive Surgery a couple of years ago at ASRM at our meeting, showing enhanced follicle numbers, but that's with technique. So let me spend a moment with that. So when you deal with an endometrioma, when you deal with any type of surgery, and this is important for everyone to know, just like patients look at IVF stats within institutions, at institutions, all of us are looked at. It's important to realize that not every surgeon does the same surgery. In fact, we wrote an article on it many years ago with Ludovico Musi from Italy called "It's the Singer, Not the Song." So it's not the endometrioma necessarily, but it's the way we do surgery on the endometrioma. And this is something that, in fact, any patient can ask their doctor. If you're removing a cyst of endometriosis, you have bleeding. If that doctor says, I'm using bipolar energy, walk away, because that will have a terribly negative impact on you. It's important that surgical technique be adhered to and be done correctly. And that's the eye of the reproductive surgeon. Mm-hmm. So again, we've now come full circle in terms of talking to our patients with what they should do, but also understanding what is the best surgery for that patient.
Yeah, I think that's a really important point. And I think endometriosis surgery is incredibly difficult and complicated. I want to switch gears a little bit to talk about C-sections and Smith-Seals or C-section niches, because we're seeing an increase in C-section rates across the U.S. Yeah. So we are, there's two different types of infertility, as you know, but for our audience, there's primary infertility for those patients that have difficulty achieving pregnancy the first time. And then we have what's called secondary infertility, which is difficulty achieving a subsequent pregnancy. And sometimes couples just have primary, sometimes couples just have secondary, sometimes couples who present with secondary also have primary. But one of the things that I've noticed in my practice that seems to be associated with secondary infertility is fluid within the uterine cavity and pronunciation of that C-section scar. Can you talk a little bit about that and what you do and how you think about this?
Yeah, this is a very, very major referral for me. I do these cases from throughout the country. I believe I have one of the largest, if not the largest, series in the world, looking at C-section scars. We look at it from a standpoint, just like you do, Eve, that the inflammation within the scar, and basically the scar occurs because the uterus, the muscle of the uterus, does not line up perfectly when the C-section is repaired. So you have this outpouching called a niche or an isthmoseal. And this tissue is inflamed. It can be endometriosis, looked at as there's endometriosis implants. It can be adenomyosis, where there's implants of endometrium-like tissue in the muscle of the uterus. So it can be on the outside, it can be on the inside. There could be other inflammatory tissues such as macrophages, etc. But this inflammation generates fluid. And because it is in this little pouch, it ends up that fluid cannot get out the cervix. So it migrates back into the uterine cavity. And we know that any type of fluid in the endometrial cavity can be disruptive.
I was just trying to see if I could get a whiteboard and draw it for our
Very good. Yeah, good job. So what on is so we go in and we take out that area and repair the uterus. So I shouldn't say that. I should say that there's three ways of repair, of dealing with the isthmoseal. If it is more shallow, we remove it hysteroscopically. So we shave down the part, the little niche, the little cave. We shave it down so that the fluid can get out through the cervix. And then we also desiccate or shave this end too, so we take care of that inflamed tissue. So that's through the uterus, but that's a smaller niche. That's done both in Europe and the United States. In China, a lot of the doctors will go in and vaginally open up this space and take out the C-section defect, repair the uterus. In the United States and Europe, we have a tendency to do this laparoscopically or hysteroscopically. So the big defects, we go in, take down the bladder, mobilize the bladder, and then cut out this isthmoseal, this defect, and then re-repair. Very good.
Right there.
Neat. Yeah. So there's the niche. Exactly. And that one would be repaired laparoscopically. That's too big for a hysteroscopic repair. And we determine size of the niche. We determine how close, how much myometrium, normal muscle, there is over the niche itself. Mm-hmm. And that's another way of determining how you should repair it, because as it gets thinner and thinner and thinner, you worry once the woman is pregnant, will there be splitting of the area unless you bolster it up with the surgical repair. Another thing that we've been doing with niches now is a niche sometimes is the place for a pregnancy. So not all ectopic pregnancies are in the fallopian tube, but may end up in the C-section defect. And we'll go in at the time of the ectopic pregnancy and actually take out the ectopic pregnancy and repair the C-section defect at the same time. In fact, we did a video for the Journal of Minimally Invasive Gynecology a few years ago showing that technique. And it's worked very well for us. Virtually everybody has become pregnant successfully afterwards.
Yeah, and I think the question, so it's very easy when someone's referred you for surgery. You're like, great, I'm going to take you to the operating room. We're going to fix your uterus. But when you are also their primary REI and you're seeing them, how do you know who needs surgery and how do you make that decision?
Okay. So yes, I mean, and even because I do get referrals from other fertility specialists, and they always go back. But I will look and I will say, hey, my experience says yes, we do this. My experience says no, we won't. So first of all, I want to know the symptoms. Obviously, if someone has fluid, I believe that that is a concern, except as you know, Eve, there's other reasons for fluid, intrauterine adhesions, dilated fallopian tube. So I want to make sure I rule that out with
Mm.
proper imaging. Number two, I look at the size of the defect. So if I know that the one thing that would say, okay, I recommend repair is if the myometrium, the muscle above the defect, is so thin or the defect is so large that I'm afraid of consequences with the pregnancy. So
Mhm.
that another reason. Although most of the time, the reason why we repair is because of fluid.
Yeah, and I think that makes a lot of sense. And I will say, sometimes we try less aggressive measures
Yeah,
to get rid of that fluid.
yes,
And again, every action that we take has risks and consequences to it. Although I think that the surgery for this is far easier and less aggressive than fibroids or
right.
endometriosis surgery.
I would add to this. I would add to this. We have, although I generally tell people that they need a cesarean section with this because obviously it's come because of labor
Mhm.
many times and dilatation of the cervix. I have had some patients who have ended up having a VBAC and being successful. That is not what I recommend. And just to tell you how you should pick and choose and get back to what your statement, brilliant statement was earlier. Um, 30% of all women after first C-section, we can see some type of line recommend that goes along with a C-section defect, even though it's not a function, it's not a
Mhm.
problem. 67% after two pregnancies, and virtually 300% after three. Not nearly all women require surgery. In fact, most do not. It's less than 5%.
Yeah. Yeah, and I think like even in terms of gestational carriers and selecting a gestational carrier makes me very nervous to select a gestational carrier who's had multiple C-sections because of
Yeah.
that risk.
I totally agree with you. It is you don't your patient who is coming in for gestational care is wants to be able to help. By the same token, you have obligation to your patient that you're helping achieve pregnancy, that you want to have them have the very best chances of having a baby, and you don't want to put that woman at risk. So it is. It oftentimes is very much a dilemma. And you start saying,
Right.
no, 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 we gotta do something easier here.
Yeah.
You're
Yeah.
right.
And I think in the last section of this webinar, I really want to focus on some of the conditions that can be treated surgically before somebody needs to have a gestational carrier.
Yeah.
So if you could talk a little bit about Asherman syndrome, what it is and how you treat it, I think that would be really helpful for
Okay.
our
So
listeners.
Asherman syndrome it's basically intrauterine adhesions. It was defined by two surgeons from Israel, Asherman and Toa. And in fact, I had the opportunity to train with Asher, the Toaf's son, years and years ago. Basically, most of the scar tissue in this study was seen in the lower part of the uterus. But over time, it has come to mean any kind of scar tissue inside the uterine cavity. Oftentimes, we see it as a disruption to menses. There can be problems with light bleeding. That's one of the questions I always ask patients. Another reason another thing that we see is bleeding between menses. But there's also and there can be problems with placentation with when pregnancy is achieved because of the scar tissue on how the placenta sticks. But oftentimes it causes problems with being able to achieve pregnancy. One of the biggest concerns I have, and certainly one of the things that we can limit, is miscarriage. When miscarriage occurs, I really believe that a hysteroscopic evacuation of the pregnancy should be performed. Number one, it allows us to understand why the pregnancy was abnormal, why it led to miscarriage. Is there a genetic related finding? But it also reduces the risk of scar tissue. And we know from a study that was done by Hooper in around 2013, the 20% of women in aggregate had scar tissue after miscarriage. So the problem is with the scar tissue is that even though you have a small amount of abnormal tissue, it talks to the entire endometrium and impacts the lining of the endometrium. As you know, the biggest problem with that is the uterus is a pseudo space. And try to fix the scarring, oftentimes the edges collapse on themselves and scarring reforms. So prevention is key, doing things that prevent the scarring. And then this is the kind of surgery that needs to be performed by skilled people who understand what to do. Oftentimes we'll go in and we'll put in stents to separate the walls for a while. We'll use products such as estrogen to help with the growth of the lining. But it's hard, as you know. It's really hard.
I mean, I think those are some of the toughest cases that we care for. And I worry sometimes that we're able to achieve a pregnancy, but some of the risks with implantation, placental development are very real and do put patients at risk down the road for things like placenta accreta and percreta and all of those. And so I think that risk benefit of, how hard do you try? How many surgeries do you do before turning to alternative measures, I think is just a careful discussion on what risks a couple is willing to take. What risks are they not willing to take?
Totally agree. On the one hand, that's not to mean that all hysteroscopic surgery is bad, because like when you deal with a septum, people who have had miscarriages or aren't getting pregnant but have a large septum. When I was your age, Eve, we had to have at least 2 miscarriages before we did a septum. Now we know what septum do.
Yeah.
And so we are much more willing to get to transect that septum earlier. And we really do have excellent results afterwards. But when it comes to intrauterine scarring that is significant, that's a tough one. And you're absolutely right. It is not an easy pregnancy necessarily once achieved.
Yeah. So we have a couple minutes left. I want to thank you so much for doing this webinar. I also want to open it up for questions. If anyone of our live audience wants to ask some questions, if you put it in the chat, Taryn, can you confirm that their names will be anonymous?
Yes, it'll go just to us. No one else will see.
We've protected it so that your anonymity can be protected for privacy reasons. But we'd love to answer any questions if anyone has any questions. And again, to be a resource for the Chicago community. I think you've explained everything so incredibly well.
Well, you know, obviously I've been doing this for a while, Lee, and it is a passion. It is a passion of mine. It is really interesting. About a year and a half ago, we had a summit of endometriosis experts in Strasbourg, France. And we were trying to come up with clinical recommendations. And it was amazing to me, with all these experts from around the world, that the discussions of pain were so verbose and so many people had so much experience. But when we started talking about fertility related issues, people just didn't know. They didn't have the experience to be able to make the recommendations. And that just shows. I mean, I just did a talk in Dubai on deep infiltrative endometriosis between the rectum and the cervix or the vagina, or deep infiltrative endometriosis of the bladder. And we know that just for a woman who is interested in fertility, we don't have to do a bowel resection at 27 to give them a good chance of pregnancy.
Yeah.
To enhance their pregnancy with surgery. No, we cut down the inflammation of the endo.
Right.
So that is something that, in the hands of a surgeon who only knows about pain, that's going to be a bowel resection.
Right.
So reproductive surgery really is key to that cross between the two islands.
Yeah. Yeah. I could not agree more. And in the cases where I feel that we really need, there are times where we need GI surgeons, but I think they are few and far between when you have a really good minimally invasive gynecologic surgeon who can help. So it doesn't look like we have questions. We
All
are
right.
at time. I, again, just wanted to thank you so much for popping on this webinar today, and for being a partner practice, and for donating services and care and commitment to the Chicago